Thank you so much for everyone joining us today. My name is Lauren Dipson, and I'm the Assistant Director at the North Dakota State University Center for Immunization, Research, and Education. We're also known as CIRE. Today, I have the pleasure of introducing Dr. Tracie Newman, who will be presenting the webinar titled Pediatric Respiratory Virus Update, COVID-19, RSV, and Flu. Dr. Tracie Newman is a board-certified pediatrician and health officer at Fargo-Cass Public Health in Fargo, North Dakota. At NDSU, she is an associate professor of practice in the Department of Public Health and the medical director of CIRE. Dr. Newman holds many other positions, including associate clinical professor at the University of North Dakota School of Medicine and policy chair for the executive committee of the American Academy of Pediatric Council on School Health. This webinar is being recorded. A publicly accessible recording will be available on the NDSU YouTube page following the presentation.
Thank you so much, Lauren. Thank you for the introduction, and thank you to everyone joining us today. We're excited to be kind of sharing this update with you, even though it doesn't feel like it quite yet. We are, in fact, entering respiratory virus season. So we hope to share with you a couple things maybe you weren't aware of, or as reminders as we all enter this for 2024-2025 season. This is just the standard CE, CME disclosure slide. I have no financial disclosures. Specifically today, we will hope to review the pediatric virus trends, really emphasizing on COVID-19 severity, mortality, and morbidity in children. We will review the disease severity, health impacts, and really comparative epi burden of other viruses like RSV and influenza. And then we'll end by outlining prevention and treatment measures for all three of these viruses, including currently recommended immunizations. So for this 2024-2025 fall and winter, we have newly formulated COVID and flu vaccines that everyone 6 months and older are recommended to receive. And now we have two options available to protect babies against RSV. We have a maternal vaccination and immunization with monoclonal antibodies that we give directly to young infants. We will outline both of these in detail today. So just to set the stage and remind us all, childhood respiratory viruses have a predictable seasonality. We know that they go up in the winter months after the start of school typically, and then decline in the summertime. COVID-19 did cause a major disruption in this typical seasonality of these viruses, with many of them actually disappearing in 2020 and 21, likely due to some of the public health measures we are taking, such as school closures, widespread masking, and others. They did come back with a vengeance, though, after we resumed normal activity with an abnormal seasonality like RSV spiking in the summer of 2021 and coming earlier than usual in the fall of 2022. And just to point out, we know that COVID-19 affects other facets of children's lives as well. In the aftermath of the pandemic, one study found that the number of public school students who were chronically absent, meaning they miss at least 10% of days in a school year, whether that's excused or unexcused, that had nearly doubled from around 15% in 2018 to 19 school year to up to 30% in the 2021-22 school year. And that's impactful because students who are chronically absent, they are at a higher risk of multiple adverse outcomes. Research shows that school absences take a toll on grades, performance on standardized tests, and we just know in general that irregular attendance can be a predictor of high school dropout, which unfortunately has been linked to, poor job prospects down the line, overall diminished health in adulthood, and even increased involvement in the criminal justice system. So these are things we want to avoid for our kids. And interestingly, we see the highest rates of pediatric hospitalization for these viruses really vary by age group and by season. So on the left, you can see for our youngest age group, children aged 0 to 4 years, RSV really predominates for hospitalizations. But then when you look at school age and adolescent age ranges, influenza seems to bring more kids into the hospital. And we are seeing a concerning trend in American attitudes related to childhood immunizations. A national poll conducted very recently, August of this year, found that only 40% of adults said it is extremely important for parents to have their children vaccinated, which has decreased from 58% in 2019 and around 64% in 01, indicating a decrease over time in the importance placed on vaccinating children, at least among some groups in the United States. Further, this poll found that a small but growing share of United States adults say vaccines are more dangerous than the diseases that they are designed to prevent. 20% now hold this view, up from 11% in 2019 and 6% in 2001. The encouraging news is, though, that time and time again, surveys tell us that Americans trust healthcare providers. As nurses, physicians, pharmacists, you really are your patient's most trusted source of information, particularly on vaccines. Yet, recent CDC data tells us around 40% of healthcare providers never or only sometimes recommend the COVID-19 vaccine to eligible pediatric patients. So as trusted entities that are held with such high regard, it's really important for us to use every opportunity to try and promote vaccination. When asked, healthcare providers report things like anticipated vaccine hesitancy or refusal as really the top reasons for not recommending COVID-19 vaccination. How did we do with vaccine coverage in the US last season? This is looking at the percent of eligible population that was vaccinated by age group. So you can see only around 15% of children received a COVID vaccine. 41% of infants got nirsevimab, and this was the RSV product, the first season it was available. Nearly 18% got the maternal RSV vaccine, and more than half of kids did get a flu vaccine. Perhaps that's been around much longer, a little more established, but we did see over half kids receive that. Okay, so we will start with COVID-19. From all the available data we have to date and kind of knowing that we anticipate high numbers with this again, I think it's worth asking, is COVID-19 really a benign illness in children, or what can we kind of expect? So we have a little polling question. This is just for you to think about and ponder, answer yourself. We don't have a method for you to actually do a poll, but true or false, from summer of last year to March of this year, the vast majority of children that were hospitalized for COVID-19 in the United States had some form of an underlying medical condition. Do you guys think that would be true or false? The answer is false, interestingly, which will show you some data around. So this is just to show you that the highest percent of emergency department visits for our youngest children, ages 0 to 4, for COVID, COVID-19 really sent kids at that age to the ED more than any other age group, including the elderly. So that's just something to note. And then during the most recent season last year, half of children under the age of 17 that were brought into the hospital for COVID did not have a comorbidity. And we saw particularly high percentages on the left there without any underlying issues in kids who are under the age of 6 months. You can see 75%. And I would point out that this is really a population where the maternal vaccine could help provide us some protection. So pediatric COVID-19 deaths have actually started decreasing since the 2022 season, which is encouraging. However, along that same time frame, we've started to see influenza deaths starting to rise, particularly again for the really young. So this slide is really to just highlight that when we compare things like COVID to other illnesses in their pre-vaccine era, this is looking at hospitalizations and deaths for each of those, that COVID-19 really holds up as something worth vaccinating for. So when you look, for example, at deaths caused every year in the United States by rotavirus before we vaccinated for it, it would maybe be around 20. For rubella, it was 17, varicella 16, and so on. And when you compare that with deaths caused by COVID-19, for our youngest kids, you're looking at 44 on average per year, older around 81. So I really think this highlights the need for vaccination for this. And this data is really after we already have a high percentage of our population who's already experienced COVID. So they may have some sort of baseline immunity, and we're still seeing this level of hospitalization and deaths in our youngest children. So I do believe it's important for us to stay up to date for COVID vaccines. Briefly, just want to touch on some of the possible long-term effects of COVID-19. There's more and more data saying vaccinating kids for COVID can help prevent some of these issues. We'll start by looking at long COVID. Defining the burden of long COVID in children has been difficult and nuanced. Some of this, challenge is due to similar to what we see in adults. Maybe there's inconsistent definitions in the studies. Studies lack control groups, things like that. Kids, of course, add a further challenge in that they can't always tell us what's wrong or what they're feeling, and they can really have a vast array of symptoms that can differ from kid to kid. So this really means we rely heavily on self-reporting of symptoms by parents or other caretakers, which can be challenging. We also don't have a specific blood test or really even a agreed upon set diagnostic criteria for pediatric long COVID. Another thing that's interesting is in really early pandemic days, due to all the measures we were taking, pediatric infections were far less common. So fewer burden of cases meant really less opportunities for us to evaluate things like long COVID. But needless to say, I tried to highlight on the left here, you can see symptoms have been reported to affect nearly every body system within kids. And multiple studies to date looking at this, we tried to pull together a few higher quality ones and summarize them on this slide. Initial studies really putting out maybe higher prevalence rates for long COVID. Some 2023 data in the United States last year showed actually very few children going on to develop what they called post-COVID-19 conditions. That would include things like long COVID. And then more recent data as of this year, 2024, maybe putting those prevalence rates a little higher. Again, just to point out, it seems to be very variable. But however low the prevalence of pediatric long COVID may be, we know that illness severity does seem to matter. So nearly 30% of children that were hospitalized for COVID-19 or MIS-C had symptoms more than a couple of months after their diagnosis. This study that was published in Pediatrics in 2022, you can see found the most common symptoms were things like fatigue, shortness of breath, cough, kind of muscle body aches, fevers. And then for kids with MIS-C, activity impairment was the most common. So just trouble doing their normal activities, especially with MIS-C. So I think the question then is, could we see an impact on chronic conditions, right? Long COVID studies have largely focused on acute symptoms like fatigue and headache that may signal, though, an underlying damage from the virus. And we know it's also important to recognize the potential impact a virus can have on a chronic condition beyond 12 months. Really, since the 1950s, viruses have been directly linked to a number of chronic conditions. I listed some examples here that are germane specifically to pediatrics. So we know, having RSV as an infant dramatically increases your chance of asthma in the first decade of life. HPV has been linked to things like cervical cancer, and so on. Various enteroviruses have been linked to things like diabetes. And we really saw the first glimpse of this looking at COVID-19 possibly triggering things like diabetes. Again, we saw the first hint of this in early 2022, a pretty landmark CDC MMWR publication came out linking SARS-CoV-2 infection to a new diagnosis of diabetes among US children. And while there was a number of limitations to this study, I do believe the biologic plausibility is there. It's certainly, we've seen it with other things, and it's definitely something we should continue to investigate. This was a really interesting cohort study that was following infants who were born in 2018 who already had at least a 10% genetic predisposition to developing multiple islet antibodies. And they were already enrolled in a trial looking at oral insulin versus placebo. And these researchers are going to follow them till the age of 3 years with sort of regular assessments, testing their islet cell antibodies, and then looking for the development of type 1 diabetes. The pandemic hit, and so then investigators decided to just add regular testing for SARS-CoV-2 antibodies as well, and then kind of following the effect on children. And they in fact did find a temporal association between SARS-CoV-2 antibody development and the subsequent islet cell autoantibody development, with a hazard ratio of about 3.5 to 5.3-fold increased risk, depending on the age of the child and depending on the time that they got their infection. I would note a very similar study was done to this of older kids, and it was published in the New England Journal, and they in fact did not find an association between SARS-CoV-2 antibodies and the subsequent risk of diabetes. So it's possible this risk remains only for or primarily in our youngest kids. And then very recently, just last week, there was a paper that came out in JAMA Open, and it found an association of COVID-19 and an increased incidence of type 2 diabetes in children and adolescents. So I think the risk is certainly seemingly here. I would look to see more and more data come out about this. But I think, like I said, findings like this really raise the question of a potential chronic disease impact from things like COVID, and I think it really underscores the need for preventing this with the use of vaccination. So we'll quickly look at COVID-19 vaccine in our kids. Recommendations on this slide are for immunocompetent children and adolescents for this current season. You can see our youngest kids, so 6 months to 4 years, are still recommended to receive a primary series in some fashion. Our school-age kids, 5 to 11, if they're up to date, they just need 1 dose of a 2024-25 either mRNA vaccine, Moderna or Pfizer. Older kids, 12 and up, they can either get, again, 1 dose of the mRNA technology, or they can receive a Novavax vaccine, the protein-based vaccine. If it's their first time getting a COVID vaccine, it's actually recommended they get 2 doses of the Novavax within the same season. So a little bit about COVID-19 vaccine composition. The 2024-25 formulations for these vaccines have been approved or authorized in the United States. It is a monovalent vaccine based on this Omicron JN1 lineage. So for the Moderna and Pfizer vaccine, they contain KP2 strain. For the Novavax vaccine, they contain the JN1 strain. And national CDC data really showing that as of this summer, really June of 2024, vaccination coverage among kids was very low, 5.8% for our youngest kids and only around 17% for our older kids. However, recent survey data tells us that while only about 30% of US parents are moderately or very concerned about their child getting COVID-19, anywhere from 35 to 57% there in the middle were confident that the vaccine is safe, and anywhere from 51 to 69% were confident that the vaccine was important to protect children. Those percentages kind of varied by age of the child. But I do think this highlights a concerning trend. We know that our youngest are at the greatest risk of severe outcomes from COVID, yet half of those parents, of children aged 6 months to 4 years are confident that COVID-19 vaccine is important. And then kind of further knowing parents' reasons for not having their child vaccinated can really help us understand why COVID-19 vaccine coverage remains low. It can also help guide our conversations as healthcare providers. This was national CDC data, survey data, looking at parents between October through December of last year. And it really shows that the most common reasons for non-vaccinating were concerns about possible side effects and safety. We tend to hear that a lot with most of our vaccines. That was around 83% for COVID-19 vaccine. And then the belief that their child is unlikely to get very sick from COVID-19, that was 52%. So sort of this underestimating this virus and the risk for their kids. And then belief that their child is unlikely, the belief that COVID vaccines don't work very well was almost half, 48%. I thought it was interesting from this as well that if you go all the way down, only a small percentage, it was 5% or less of children or had a parent reporting access issues. So people have this available to them, they're just choosing not to get it. Like any vaccine, there are possible side effects, which can vary. They're typically mild and self-limiting. And COVID-19 vaccines have undergone the most extensive safety analysis really in US history, because of the updated COVID-19 vaccines for the 2024-25 season are very similar to previous mRNA vaccines that we used. Their safety is firmly supported by data from earlier clinical trials and from complementary vaccine safety monitoring systems that we have in the United States. So we know this vaccination is safe. While adverse outcomes are rare, the benefit of a COVID-19 vaccine really outweighs the known risks of COVID-19 infection and possible severe complications for our kids. The data kind of continue to be reassuring about the safety of this vaccine, especially in pediatric populations. I thought we could look at some of the most recent research. This was published in May of this year, looking at over 5 million young people aged 5 to 17 years in England. These researchers examined the risk of vaccine safety outcomes following COVID-19 vaccine and then SARS-CoV-2 infection. They stratified this by age group and by sex. And really, they found no strong evidence for increased risk of any of the 12 safety outcomes that they investigated. And those included things that maybe people worry about, like MIS-C, myocarditis, etc. And additionally, children who had not received a COVID-19 vaccine prior to getting a SARS-CoV-2 infection, they had an increased risk of hospitalization from 7 of these pre-specified safety outcomes, again, including big ones like MIS-C. And then finally, the risk of safety outcomes from SARS-CoV-2 infection were largely absent in kids who received at least 1 dose of the vaccine prior to getting their infection. Kind of interesting data. Another one, this was published in Pediatrics last year in 2023, just kind of highlighting they did an important analysis of kids aged 5 and under using surveillance data of a large pool of mRNA vaccine, and they really found no safety signal for any of the outcomes, at least following them 21 days out. This involved use of things like our VSD, which is a large collaboration between the CDC and multiple other data contributing health systems. But I think the bottom line is they really didn't find any safety signals after following a large amount of children being vaccinated. But what about this concern about myocarditis and pericarditis? It is something that we, I think, previously heard a little more about, but still do hear about. I think the summary here is that the benefits really outweigh the risk in any age group for which there might be, including ages where the risk might be the highest for myocarditis. In summary here, we compared with myocarditis associated with COVID-19 disease. We know that myocarditis after vaccination occurs much less frequently, and it's associated with a better clinical outcome. So kind of trying to put that risk in perspective, there are multiple studies looking at this. When you're looking at the chance of getting myocarditis after various things, I think the bottom line is really the benefits of getting vaccinated markedly outweigh the very small risk of vaccine-related myocarditis. So we know COVID-19 vaccination prevents most hospitalizations and deaths. It's clear that vaccination can protect you from myocarditis itself by protecting you from getting a COVID-19 infection. This was some 2023 through 24 COVID-19 vaccination data showing it provided an increased protection against symptomatic infection and then COVID-19 associated things like ED and urgent care visits and hospitalizations when compared to not receiving a dose. The coverage, the immunity did wane, but it seemed to be similar for most vaccine formulations, especially for preventing critical illness. So an estimated 1 to 3% of children with SARS-CoV-2 infection will go on to develop a post-COVID-19 condition, depending which data you look at, like I showed you earlier. This study really evaluated the mRNA COVID-19 vaccine's impact on the likelihood of going on to develop a PCC in kids. And so the adjusted odds ratio corresponded to an estimated 34% reduced likelihood of more than one and 48% reduced likelihood of more than two symptoms. And then you can see a 47% reduction in developing any respiratory symptoms. Another large retrospective study looking at over 1 million kids ages 5 to 17, this was published this year in Pediatrics. It showed that vaccination provides a 35% effectiveness against probable long COVID and 42% protection against diagnosed with long COVID within a year of receiving the vaccine. Protection was more robust for adolescents, and it did wane somewhat over time. MIS-C patients and illness onset in 2023, these were predominantly unvaccinated kids and those whose vaccine-induced immunity had likely waned. So COVID-19 vaccination remains an important tool for preventing severe outcomes like MIS-C. Multiple studies have found that the COVID-19 vaccine is effective at reducing the risk of this. One CDC study found that 2 doses of Pfizer vaccine had a greater than 90% effectiveness at preventing MIS-C. And while we did see substantially less cases of this in last season in 2023, I think it's worth noting that 58% were previously healthy kids with no underlying medical conditions, and 50% of them actually required an elevated level of care in PICUs, and the vast majority of them were either or under vaccinated. So this is a question that we get sometimes when a patient has recently had COVID-19, when should they receive an updated vaccine? I think that in general, it's recommended to wait 2 to 3 months, at least 3 months after your infection before getting a COVID vaccine dose. However, these timing decisions can really vary based on your underlying situation. It's always something to speak with your provider about. Some experts say if you were recently infected, you can even wait somewhere like 4 to 6 months. It doesn't hurt to get it earlier in that 2 to 3 month time frame. And there is actually some research out there to say that waiting anywhere of 8 to 12 months out can allow antibodies to kind of update more effectively. So it can really vary depending on perhaps the timing or severity of your infection and your underlying health status. Okay, switching to RSV. We know this virus, we are very familiar with it in pediatrics. Almost nearly every child by their 2nd birthday has become infected with respiratory syncytial virus. This is the most common cause of infant hospitalization in this country. And you can see shown here on the bottom, your risk does increase the younger that you are. Specifically, this is the #1 cause of hospitalization, like I said, in our infants. And what's interesting is being born early or having an underlying chronic condition, of course, would increase your risk, but close to 80% of kids who are hospitalized for this virus actually have no underlying medical conditions. Each year in the US, for children under the age of 5, the RSV is associated with anywhere from 100 to 300 deaths, upwards of 80,000 hospitalizations, over 500,000 trips to the emergency department, and around 1.5 million outpatient visits. So quite a substantial burden on our children and our healthcare system. Again, looking at that seasonality, in most regions of the United States, RSV season typically starts during the fall and will peak during the winter. You can see it typically peaks around December to January. It did peak earlier than usual in that 2022 season, that red line. It arrived in October, and we actually saw cases peak in November. And this was particularly a severe season for our youngest kids under the age of 5. A recent retrospective cohort study, this was published in JAMA Pediatrics at the end of last year. It showed that pediatric hospitalization rates were actually much higher for RSV. You can see in the pink line, somewhere around 80, 81%, Then for Omicron strain of SARS-CoV-2, I thought that was interesting because Omicron had probably the most severity we've seen in our pediatric complication. You can see RSV far outstrips that, and it outstrips things like influenza. They looked at both A and B strains shown in the blue. Interestingly, from this, ICU rates were also the highest for RSV. A stat from this study was the odds of newborns and infants under a year being hospitalized for RSV were around 11 times higher than for Omicron. So I think data like this really underscores the need for preventative and life-saving measures that we now have available for RSV. So what are some of those ways that we can prevent this? We'll have another polling question for you to think about. All of the following are examples of passive immunization, except A, transplacental, B, mom to baby through breastfeeding, C, a child receiving a vaccine, or D, an infant receiving nirsevimab. Let you guys think about that. So the answer is D, a child receiving COVID-19 vaccine, and we'll kind of walk through that here. So just to clarify a little bit, nirsevimab is not actually a vaccine. It is passive immunization with long-acting monoclonal antibody. So active immunity results when a person either gets an infection or gets a vaccine, and that triggers your own immune system to create antibodies and create an immune response. This often will last much longer, not always, but often, and sometimes a lifetime. Passive immunity is when we give a patient or a person already formed antibodies from an external source. So this can be, again, transplacentally from mom to baby. It can be through breast milk. It can be when we give patients IVIG, or in this case, monoclonal antibodies, which is technically what nirsevimab is. So it is a form of immunizing for RSV. The current recommendations are that all babies under the age of 8 months, if they're either about to enter or if they're in RSV season, it is recommended they receive this. And then a certain subset of older children are recommended to receive it a second season if they remain at high risk for severe disease by RSV. I would point out for our region that American Indian children fall into that group. And except in very rare circumstances, there's a small list of things where a baby would need both mom to be vaccinated during pregnancy and get nirsevimab. Generally speaking, it would be one or the other. In clinical trials, both of these products were shown to be safe and effective at preventing RSV in infants. You can kind of see this was the first season this was available was last year. And when we look at our effectiveness data, so real world data, how did it do? It decreased by about 89% medically attended RSV respiratory illness, and then it reduced the risk of hospitalization by 91%. So high levels of effectiveness. This is just a little bit about nirsevimab administration. So ideally, this would be given during RSV season, so October through March. And it would be preferred that an infant receive this during their birth hospitalization or at the latest within 1 week of birth. Unfortunately, due to things like high costs of this product, trouble getting it bundled in insurance plans and workflow concerns, many of our local birthing hospitals actually here in North Dakota will not be offering nirsevimab. So this is going to fall to outpatient pediatrics by and large. And this is on the right, a really nice flow chart that I reference and use. It's put out by the American Academy of Pediatrics. I believe they have printable PDFs if that's helpful for you, but it really starts with, are you in the right season? It looks at the patient's risk and their age, and then it kind of ends actually on the exact dose and their weight that you would give. So very helpful clinical tool. This is some observational data indicating, again, nirsevimab is working kind of as expected versus randomized controlled trials. This was, again, during the very first season last year during 2023. And you can just kind of see multiple studies really highlighted here that are showing high vaccine effectiveness. In fact, infants who received nirsevimab during the 2023-24 season had around a 76% less likely chance of visiting a healthcare provider due to RSV. They had anywhere of a 70 to 90% less chance of being hospitalized, and an 80% less chance of coming into the PICU for RSV. Despite this product being so effective and safe, uptake was low last season. According to some very recent survey data, the main reasons for definitely or probably not getting nirsevimab included concerns about long-term safety, that was 19%, not planning to get the infant any vaccines was almost 17%, and not wanting the infant to receive too many vaccines. That's a common one we've heard for many years in pediatrics. Switching briefly to the maternal vaccine, so Abrysvo was the first RSV vaccine for pregnancy that was approved in the United States. It is meant to be given to moms during the end of their pregnancy, 32 to 36 weeks gestation, and then it provides protection for babies from the time of birth till around 6 months of age. Again, safety and effectiveness was very good in pre-licensure studies. We have ongoing evaluation of this in randomized, very large placebo-controlled trials internationally. Some of that preliminary data, though, has shown an almost 82% reduced risk of severe disease within the first 3 months of birth, and around 70% protection of severe disease out to being 6 months old. In the phase 3 clinical trials, so data published in the New England Journal, maternal RSV vaccine actually reduced the risk of the baby being hospitalized for RSV by about 68%, and then having a healthcare visit by 57%, again, within that first 3 months after birth. In the same trial, the maternal vaccine reduced the risk of hospitalization by 57% and an outpatient visit by 51% out to 6 months after birth. In clinical trials, the most common reported side effects for pregnant people who received Abrysvo were typical things: pain at the injection site, headache, myalgia, nausea. A quick note about preterm birth, in case you are asked about this. People in the initial clinical trial for this product were getting the maternal vaccine between 24 weeks up to 36 weeks gestation. And more preterm births were observed among vaccine recipients versus placebo. However, that difference was not statistically significant. People in this trial who received either the maternal RSV vaccine or placebo kind of later, so in that 32 to 36 weeks, preterm birth, you can see here, occurred 4.2% in the vaccine group and 3.7% in placebo. So available data are really insufficient to exclude or establish a causal relationship between preterm birth and Abrysvo, but in an abundance of caution to reduce any potential risk of preterm birth, the FDA approved this use only for that 32 to 36 weeks of pregnancy. And this was a follow-up study that was conducted and published again in JAMA of this year. So you can kind of see the vaccine was found to be safe and protective in a real-world setting. This looked at over 1,000 vaccinated participants and almost 2,000 unvaccinated. This data was from 2 large hospitals in the New York City area. Preterm birth was defined as before 37 weeks. And 60 patients who received the prenatal vaccine, so about 6%, experienced preterm birth, while 6.7 of those did not. So I really think real-world data like this can provide us some reassurance about the vaccine safety during pregnancy. And while Abrysvo, which is the Pfizer product, is safe and effective for pregnant women, just for your information, again, in case you're asked by patients or you see information online, GSK was developing another maternal vaccine, and this actually stopped the clinical trial early. So it's important, again, to point out, we don't know if the safety signal was real or occurred by chance, but they halted this trial anyway. And then they went on to publish the trial data in the New England Journal of Medicine. So preterm births were higher in the vaccine group compared to placebo, 6.8% versus almost 5%. Of the preterm births, about 5.5% in the vaccine group were very preterm, so that was less than 32 weeks, or extremely preterm, less than 28 weeks, compared to placebo at 2.3%. And then a higher risk of neonatal death was noted in the vaccine group, again, maybe perhaps due to extreme prematurity. But because of this, the trial was stopped and this vaccine was never released. This was that publication. So you can kind of see that the results of this trial, which enrollment was stopped early because of safety concerns, suggest the risk of any and severely medically assessed RSV in infants was lower in the candidate. So basically they saw less medically attended RSV in vaccine groups versus placebo, but because of this potential risk of preterm birth, this product never came to market. A little more specifics, for every 54 babies born in the vaccine group, 1 additional preterm birth occurred. The mechanism of increased risk and whether or not this was a true, statistically significant risk remains unknown. Okay, and then although not common in clinical trials, another thing was hypertensive disorders of pregnancy, so including things like preeclampsia. Those occurred in 1.8% of pregnant people who got the vaccine compared to 1.4% who got placebo. Preeclampsia, low birth weight, so meaning under 5.5 pounds, and jaundice in newborns occurred more frequently in infants born to moms who got the RSV vaccine compared to moms who didn't. So these conditions are often associated with preterm birth, and the data reviewed in detail by ACIP supported limiting the vaccine administration, again, to that 32 to 36 weeks gestation, and that this reduced any potential risk for preterm birth and thereby the potential for these related complications that we might see if we were giving it 24 to 36 weeks gestation. The FDA is requiring the manufacturer to do additional studies that will look more closely at these potential risks of preterm births. And then additionally, in the United States, CDC will monitor, vaccine safety using all of the systems we normally use, like VAERS and Vaccine Safety Data Link, et cetera. And then just importantly, the ACIP did judge the benefits of this maternal vaccine to outweigh the potential risks for preterm birth and things like hypertensive disorders of pregnancy. So knowing all that, how many US women received the RSV maternal vaccine during its first season available? As of January of this year, which would have been the end of the recommended period, there was an overall coverage of 17.9%. This slide is broken out by ethnicity. So our coverage rates are highest in non-Hispanic Asians, about 25% in the red line, and they were lowest in non-Hispanic Blacks in the green line. So we may have some work to do in getting the message out about the importance of this vaccine, maybe some targeted public health interventions to certain groups. How did we do here in North Dakota? The NDHHS maintains an internal dashboard that tracks sort of RSV immunization data. Last season, 1,373 doses of Abrysvo were given to women under the age of 50 years. It is presumed those were pregnant women in the 2023-24 season. In April of this year, a little more survey data. I thought this one was really interesting, showing mostly positive attitudes toward the RSV vaccine in pregnancy. This was published in Pediatrics. This showed that if women perceived RSV to be a serious threat, or that they thought this virus was going to cause a serious illness in their infants, they were much more likely to get vaccinated during pregnancy at around 40%. And so actually 54% of these respondents indicated they were very likely to get vaccine against RSV during pregnancy. It also found if they had other small children at home, they were more likely to get this vaccine, or if vaccination in past pregnancies to other things was linked to a willingness to receive RSV vaccine. So I think maybe study information like this is important for us to discuss with our patients the seriousness of things like RSV. 2024 CDC MMWR, this was in determining product preference. So you can see 38.1% of people preferred to receive the maternal RSV vaccine, 27.8% preferred nirsevimab for their baby, 21.3% had no preference, and then 12.8% would not get either, basically, for their infant. Among those who preferred the maternal RSV vaccine, 47.8% believed that that would be safer, 30% worried about their infant getting too many shots after birth, and then another third or so believed the maternal vaccine would actually be more effective. In the group who preferred nirsevimab, 43% believed that it would be more effective and work better, and then about another third believed it would be safer. So it's just a nice little summary slide for you, looking at the advantages and disadvantages between the two products. For when we vaccinate moms in the maternal vaccine, you can get immediate protection during birth, so you don't have to worry about waiting each day to maybe get nirsevimab, and then it reduces the number of pokes per baby, which most families like. Some disadvantages, it might not, mom may not mount an appropriate response, or she may not transfer antibodies to baby for whatever reason. There's maybe this other potential preterm risk of things I was just reviewing with you, like preterm births and hypertensive disorders, that's still kind of being examined. Giving a baby nirsevimab has the advantage of giving protection that may last a little bit longer. It's thought maybe this protection from the maternal vaccine can wane sooner. You're giving direct already formed antibodies rather than relying on the transfer, transplacentally. And then there's, not running a risk of any pregnancy outcomes for mom. This does require a poke for baby, and there could be a delay in getting the product, leaving baby unprotected in their most at-risk time. Again, just summarizing the seasonal recommendations for these products. So people who are 32 to 36 weeks pregnant during September through January are recommended to get 1 dose of the maternal vaccine to protect their babies. RSV season can vary around the country. This is for the majority of mainland United States. Nirsevimab is recommended for babies, again, typically October through March. So another interesting question that we get. So should a pregnant person receive a maternal RSV vaccine if they received a maternal RSV vaccine during their pregnancy in a previous season? The answer is actually no. So people who received maternal vaccine during a previous pregnancy are not recommended to receive additional doses during future pregnancies. Infants born to women in those situations are recommended to receive nirsevimab. We will end here on influenza. So a couple of statistics about flu and kids. We know every year the disease burden is quite high in our pediatric population. Around 10% of kids in this country will develop symptomatic flu. Hospitalization rates, if you remember our graphs, are higher in kids under 5 years of age. Viral infections such as influenza can lead to serious and secondary bacterial infections. And then somewhere around 8 to 11% of children hospitalized for things like flu experience neurologic complications. Again, looking at seasonality, influenza arrived earlier than usual in 2022, peaking kind of in that mid-November. We do think influenza seasonality is actually shifting back to the pre-pandemic things that we were used to. Typically, we see this come around fall and then peak mid-January or so. That is predicted to occur this season as well. Flu hospitalization rates, this is per 100,000 population. Among kids for last season, 2023-24, what you can kind of see is that young children, that gold line is 0 to 4 years, had the highest rate of flu hospitalization. And we know that flu vaccines cut the risk of flu hospitalization by about half in kids who are vaccinated compared to those who aren't. Flu severity in kids, interestingly, last season, pediatric flu deaths exceeded our previously high that had been reported for a non-pandemic flu season. We had over 200 pediatric deaths due to the flu last year. 80% of those flu-associated deaths occurred in unvaccinated children. A little bit about flu vaccine for kids. You can see here that kids, so the annual flu vaccine is recommended for everyone 6 months and older. That is unchanged. Our current formulation for this season will be a trivalent. It targets 2 flu A viruses, H1N1 and then H3N2, and then it targets a B virus or Victoria strain. This is recommended for kids to get 1 or both doses by the end of October, kind of our say boo to the flu. To the right here is just showing a flow chart. If If a child is under a certain age and has never received a flu vaccine, it is recommended they get 2 the first time. If they've received previous doses, they only need 1 this season. And then, of course, pregnant moms or fathers or grandparents, any caretakers, we really encourage to be vaccinated for the flu to kind of provide that cocooning protection for infants and newborns who are highest risk. And this flu vaccines can be given with any other childhood vaccinations. Children who got last season's flu vaccine were anywhere from around 60 to 67% less likely to need to have an outpatient visit due to the flu, and they were 52 to 61% less likely to require hospitalization. In the United States, flu vaccination coverage among children and adolescents continues to decline post-pandemic, most notably among white children and among adults under the age of 65. So during the 2023-24 season, approximately half of children and adults received a flu vaccine. The last flu season that coverage was lower than this season's level was about 12 seasons ago for kids and about 6 or so seasons ago for adults. You can see before the COVID-19 pandemic, flu coverage had actually been slowly increasing. And so downturns in coverage began during and right after the pandemic. Unfortunately, flu vaccination levels have not kind of rebounded pre-pandemic, and they remain far below our Healthy People 2023 kind of goal of 70% of coverage for people 6 months and older. Consistently, data shows that children living in rural areas have far lower vaccine coverage than those in urban areas. In this particular study, it was about 20% lower. Another gap for maybe targeted public health interventions. And in North Dakota, last season, our pediatric flu coverage for our state, our youngest kiddos, it was around 35%, school age around 25%, adolescents about 22-23%. North Dakota is ranked number 36 out of 50 for pediatric flu vaccine coverage. And again, I would just point out the overall decline that we've seen in that from pandemic years. This is the sort of respiratory season outlook that is predicted based on modeling studies and groups of experts. You can see for the 2024-25 upcoming season, it is thought that peak hospitalization burdens will be similar to or even lower than last year, and maybe in keeping with recent seasons we've had. This is pooling data for all 3 of the viruses we've talked about today: COVID, influenza, and RSV. So a little summary here of the info we presented to you today. This is for your reference. I think, for COVID, just to remember that rates of COVID-associated hospitalization, we really see that occur in our most youngest and vulnerable children under the age of 4. Particularly, we see higher rates in kids under the age of 6 months. Over half of children who were hospitalized last season had no underlying medical conditions. Everyone 6 months and older is recommended to stay up to date on COVID vaccines this season. Pediatric COVID vaccines reduce the risk of hospitalization, MIS-C, long COVID, and even death from this virus. But unfortunately, vaccine coverage does, and intent does remain quite low. RSV is the most common cause of hospitalization among infants. We have 2 options for preventing this season, either a maternal vaccine or a monoclonal antibody. Both options are highly safe and effective. Nirsevimab should ideally be administered right at birth or within the first week following that. Maternal RSV vaccine is given seasonally and to women 32 to 36 weeks pregnant. And finally, flu. Last season, the flu was particularly severe for our youngest patients. We saw pediatric deaths at a recent high at 201. Again, everyone 6 months and older should get an annual flu shot. Last season's flu vaccine reduced the risk of healthcare visits and hospitalization substantially. Flu vaccine coverage has really decreased markedly over time, with last season's rates in particular reaching the lowest that we've seen in over a decade or so. And then always important to remember that you are your patient's most trusted source of information. Again, this is a similar slide as how we started. Everyone 6 months and older is recommended this season to get a COVID and flu vaccine. For protection against RSV, we have two options: vaccinating our pregnant women seasonally between 32 to 36 weeks, or directly giving infants under the age of 8 months monoclonal antibodies. But we are happy to take any questions.
Um, I guess maybe we have time, Tracie, for maybe one question. I don't see any in the Q&A yet, but I know one of the questions we had yesterday that we maybe didn't get to was, is there going to actually be maybe potentially an at-home flu mist type vaccination available to the public maybe next year? And do you want to talk about that?
Yeah, great question and exciting new potential. Yes, it does sound like that is in the works and has been approved for it would be the 2025-26 season. It will be similar to, products. It's a live flu vaccine given intranasally. It's approved for everyone 2 and older. It must be administered though by someone 18 or older. So it can be done at home by a caregiver or parent, things like that. It will require a prescription, it sounds like, but it will not require a visit to the physician or to the medical office to be administered. And it's my understanding that pharmacists would be able to prescribe things like that as well. So
Wonderful.
we hope to see an increased uptake with ease of things like that, but yeah.
Absolutely. And maybe we have maybe enough time for one more question.
Sure.
Yesterday we talked about this, and is a maybe potentially a great thing to talk about is maybe how pertussis in our community here in Fargo and how that might impact our respiratory season this year.
Yeah, thank you for the question. We are currently experiencing, unfortunately, a pertussis outbreak in the entire state of North Dakota. It's been primarily focused around Cass County. And so, yeah, you always worry if resources are being used and attention is being used to that with the upcoming preceding, respiratory season coming. We're kind of already strained a little bit in public health and in our clinics. But unfortunately for things like pertussis, we have a very effective vaccine available. So we encourage everyone to ensure their kids are either up to date with DTaP or adolescents for Tdap, and even adults too. Prophylaxis we use the form of prophylaxis for things like pertussis. So if you are exposed or a family member has it, we actually give antibiotics to all household contacts and things like that. So our health department is very good about tracking and case finding and trying to provide protection. But yeah, we are already a little strained and already experiencing far more pertussis and respiratory cases than we're used to entering this upcoming respiratory season. It's a great point, Lauren.
Well, thank you so much for a wonderful presentation. We're right at 1 p.m. So thank you all for joining us today.